Good afternoon, everyone. I am Amy Cullum, a consultant with JSI, and together with Margaret Franckhauser, JSI's Director of Aging Services, I'd like to welcome you to our Lunch and Learn, where we are going to explore global lessons learned in vaccine distribution and how they can be applied to current efforts in the US to increase equity in vaccine rollout. This panel brings together experts working in varied but complementary roles in infectious disease, immunization, and community health, to explore how new vaccines have been introduced effectively in countries around the world. We will consider how new vaccines have been delivered to the last mile, to the most remote and difficult to reach communities and individuals. And we'll discuss how those international approaches might serve as models in the United States for doing a better job reaching populations that our systems have traditionally failed to reach, which is an issue of critical importance as the nation works to turn this pandemic and return to fully engaged national life. I wanted to give a quick introduction to our panelists. So first I will introduce Durrell Fox. He is a health equity consultant at JSI and a community health worker with almost 30 years of experience providing community and street outreach, direct services, case management support, and advocacy for adolescents and young adults, their families, and communities.
Thank you, Andy.
Wendy Prosser is a senior technical advisor at JSI's Immunization Center. For 2 decades, her focus has been on putting the logic back into logistics, bridging technology and common sense to strengthen immunization supply chains across Africa and South Asia. And Dr. Elizabeth Talbot is an infectious diseases and tropical medicine trained internist, a professor of medicine at Dartmouth's Geisel Medical School and New Hampshire's deputy state epidemiologist. Dr. Talbot has extensive experience in international and domestic infectious disease control, including tuberculosis, Ebola, and COVID-19. So what we'll do is we'll pose some questions to our panel of experts to garner their insights on the issues, and we will welcome your questions in the chat to inform our discussion at the close of the session. Also, if you have any questions that you'd like to direct to a particular speaker, please be sure to indicate that in your chat. So without further delay, I would like to pose the first question to our panel, and Durrell, I think I'll start with you. And I would like to ask you, in your years of experience as a community health worker, what are the primary challenges that you see in the vaccine campaign effort in the United States? I don't think we're actually hearing Durrell.
Yeah, I'm not.
Oh, Durrell, you're not on mute, are you? Try again.
Nope, still not working.
So, Wendy, oh, here comes Malcolm to try to help.
Yeah, I was gonna say, do you have many tabs open or any other, like, do you have Zoom open or any other program that might interfere? Yeah, so hopefully, I mean, maybe you can try coming out and coming back, but we are going to figure this out.
Okay, so Durrell's going to try to come in and come back out. And then how about, Wendy, if I pose the same question to you first with all your years of international experience?
Sure thing. One of what I find is a kind of an oddly exciting thing about this new COVID vaccine is that the supply chain has become quite prominent in the headlines because the vaccine requires such a unique cold chain here in the States. As we all know, I'm sure you all know by now, the vaccines have to be kept colder to maintain their potency and efficacy. And especially with the Pfizer vaccine that requires negative 80 degrees Celsius and Moderna that's down to negative 20 degrees Celsius, the cold chain technology that's required for that is new and it's developing all the time. And it also has not been very widely available. So it's been a significant challenge to see how it's been rolled out. And knowing how to best manage the vaccine through the storage from manufacturer until administered in someone's arm has been, I think, one of the main challenges that we've seen from the supply chain perspective.
Okay, so let me go to Dr. Talbot. Dr. Talbot, from your perspective, what are the challenges that the U.S. is facing?
I hate to preface it. I mean, there's so many challenges to choose among, right? I mean, we have so many steps to accomplish safe, effective, and equitable shots to arms. The development of the vaccine, the allocation decisions, distribution, as Wendy took on a bit, administration, and then the underlying communication that makes it all happen. Because vaccine hesitancy certainly has emerged as a huge challenge for us. I think, though, in terms of choosing one, I'd like to say the tough situation for us in state public health that also resonates with other of my global efforts in public health has been the pace, presentation, and undermining of the emerging science. So this has been an incredibly frustrating space for so many of us, having to learn about vaccine efficacy, for example, in a press release rather than a peer-reviewed journal article like the New England Journal or so, having to communicate to vaccine hesitant persons who are tethered to political beliefs that maybe are mired in conspiracy theories and a deep distrust of science. And I think it's been ever so important to lead with about what we know, what we believe, what we think, or even what we just hope. That has been a recurring challenge for us in state public health leadership. And I'm repeatedly reminded of the importance to balance that leadership with humility. We have all been working in an absolute peak of stress, maybe the highest of our entire careers. So we have to be open to recognize the strengths and weaknesses that this evokes. Many of us are nearing burnout, of course. We're emotionally exhausted. Some of us are not sleeping well or as much as we want to, or we have interrupted sleep from dreaming about COVID, which has been this bizarre phenomenon for me, or with our own personal loss or stress. We assume everyone is coming from a place of trauma and vulnerability, and we have a collective need to optimize resilience, especially as we are without the data we need or want. At every moment, we have to take decisions about this vaccine distribution and allocation. And so we're learning phrases like, we believe the science is telling us X, Y, or Z. We're doing the best we can to balance outbreak control with other aspects of the public health. And then those very difficult phrases, I'm sorry, I made a mistake, I was wrong, being able to go back to the basics. That's important in every one of our professional and personal roles in life. So again, I think the pace, presentation, and undermining of emerging science has been a really hard space for me in state public health, teaching us humility and a need to frame our guidance in this kind of dynamic space.
Can you guys hear my audio?
Yes, we can, Durrell. So Durrell, please, I know you probably have a lot to say about that and the initial question, which was about the challenges in the US.
Yeah, I'll be brief. I know I hear an echo, but I know we have a diverse audience. So I wanted to take a moment and step back and give a brief definition of a community health worker. A community health worker is a frontline public health worker who is a trusted member of and/or has a usually close understanding of the community they serve. They build trusting relationships that enable them to serve as a liaison, a link, an intermediary between health, social services, and the community to facilitate access to services. They improve individual and community capacity by providing outreach, education, information, social support, and advocacy. I say this because the CHW workforce is designed in a way to really be a good steward and ambassador to address COVID-19. I've seen many challenges in the US, many have been documented. I know Wendy talked about supply chain, but once it gets to the community, there's inequitable distribution and allocation of vaccine doses available to people in underserved communities. And forgive me, I have an echo, so I'll have to deal with that for the next question. Can you hear the echo?
We can hear the echo, but we can still hear you. So
Okay, so I'll just keep going.
Maybe try one more time when we move on to the next question.
Yeah, so the bottom line is racial and socioeconomic disparities have been documented in COVID-19 testing and vaccination systems. because these systems weren't designed with community members that need the services in mind. Some examples include vaccination sites set up in communities of color to address inequitable distribution and access to vaccines, but when you review the data about who accessed that site, the majority of the vaccination appointments were by other members from other communities, from other places, actually blocking access to those very community members the site was designed to be support. Another thing that happens is you actually need to have a car to use a drive-through vaccination or testing site. Many of us work with communities where a lot of folks do not have cars to use public transportation. So if you're depending on a system of vaccinations and of testing that depends on drive-through, you're not going to reach a lot of the folks that you're trying to reach in communities. The other piece is related to the systems that we use, usually digital, to register and book appointments. And due to the digital divide, some of these aren't accessible to many poor, urban, and rural community centers, folks who live there. While some communities have solid access to the internet, there are many who do not. So how do you design something that has to use a computer, smartphone, and have internet access when we know that there are so many people that depend on phone calls and face-to-face to get their services? And then finally, I'll just say there really has been a lack of, and I think Dr. Talbot mentioned this, of clear, culturally and linguistically appropriate information about vaccine options. Later on, I'll talk about some of the initiatives and how CHWs and community members are addressing this, but there's been really a lack of information designed with the health aid lens and the understanding of the diversities and languages of the many communities that we need to reach for COVID-19. I'll stop there and try to deal with my technical issue. Thank you.
Yeah, thank you, Durrell. I'm glad we could hear all of yours and everybody's points. Jump back in and out, and we'll listen to you again. And I'm gonna pose another question to our panel. So, I know that all of you have had long careers in public health and healthcare, and I'm wondering what similar challenges you've seen over the course of your career. There have been a few that you've mentioned already, I think, and then, what are the lessons learned that you draw from those challenges that you've seen in the course of your career, and what do you think is transferable to this situation? Wendy, go ahead.
Well, I'm on the edge of my seat to maybe kick it off, if you don't mind. I just can spend the rest of my life trying to digest the lessons learned in my career from the Ebola epidemic, 2014-16. So if you'll indulge me to reminisce that a moment, I know many people here probably also were engaged there, and there are so many parallels. So I was deployed with the International Medical Corps, and my focus was to implement training for the cadre of incredibly brave health workers who are arriving to support the communities in the 3 impacted countries. So many outbreak parallels here, such as, an across the board fear, panic, if you will, about the emerging virus, because there's so many unknowns, right? The critical steep learning curve of case management and the transmission dynamics. Your life depended on knowing this. So there are some differences, but that really came home to me, that the fear was not only in the communities, but in the healthcare workers who had endured the loss of their colleagues and countrymen because of pretty evil transmission dynamics of that. Everybody was forced to adjust to these changing recommendations about PPE that could save your life or not, but also there was a rapid development, distribution, communication, and collaboration that had to emerge around the novel vaccines. So many of you know there are 2 vaccines for Ebola that are also shown to be very safe and effective, in fact, overlapping with the Johnson & Johnson vaccine, the same technologies. That cascade of care toward the ring vaccination for last mile populations in every corner of the 3 affected countries, then it's similar to what we're facing for COVID vaccination here in rural New Hampshire, and I'm sure in many of your other jurisdictions. So what are the lessons learned? it's incredibly dynamic situations is not really where humans like to dwell. We like to be sure, and we like to know and feel comfortable, but we all need to dig deep within to find that willingness to approach challenges in new and nimble ways, rather than trying to fit them into any previous mold. I truly believe that's when the best and most effective solutions can materialize. So both the Ebola epidemic and the COVID-19 pandemic have demanded this kind of new level of flexibility across the entire spectrum of response, for heaven's sakes, from national, state, and public health leadership to the many stakeholders, the health workers, the patients, and their communities. So this extends not only in the professional arena, but being flexible personally as well. Again, I recognize that many of you listening have suffered personal loss from this particular pandemic, or stress in your family as people have been forced home in new ways that they had not previously prepared for. Uniquely within Ebola, I'd offer that the response was disproportionately, especially the leadership of this response, was disproportionately made up of foreigners, often different skin color, right? And there was an avalanche of misinformation that was accelerated even without the typical electronic social media that amplifies our own misinformation campaigns. So I would suggest, I hope we're all preparing for our roles in and staying nimble, especially with regards to vaccination, because my fear, drum roll please, is that we are all about to pivot from navigating the extremely high demand for vaccines to a low demand as we encounter the population who's vaccine hesitant. I think we have a heavy lift ahead. And even though we're in a phase where there might be light at the end of the tunnel, that tunnel is long. So staying nimble, staying flexible, and being willing to come up with new solutions to these awesome challenges. That's what I would say resonates with your question. So thank you, Amy.
Thank you very much.
Just want to test my audio. Can you guys hear me?
Yes.
Okay.
You sound great.
All right. I'm in queue. I'll be in queue.
Okay.
Order.
So Wendy, what about you? You've been around for a long time working on supply chain in all sorts of countries. What are the challenges you've lived through, and what could you bring to bear, do you think?
Yeah, that's a great question, because we have learned a lot from working globally with the immunization supply chain. First, I'd like to ask, by a show of virtual hands or in the chat, who stocked up on toilet paper a year ago when the pandemic hit in this country? There was that whole frenetic flurry of, oh my gosh, we're gonna run out of toilet paper. I'm guilty. I did it as soon as I saw, an available toilet paper, I'd grab it, right? So some people tried to, you had to then borrow from your neighbors. It happened. What's fascinating to me about that is that as a country, we were not out of toilet paper, but we were out of toilet paper in the sizes that we use in our home. And so the demand shifted dramatically and overnight from the large rolls that offices and public spaces use to having the demand needed and required for our homes. And so the design of the packaging couldn't change overnight. And the same is applied. So yeah, what does this do with the vaccine, the COVID vaccine? The same is about the packaging. So right now the COVID vaccine requires ultra cold chain, but also it's designed to reach lots of people at one big time. So the vials themselves have 6 or 10 doses, and they have to be used within 6 hours. So it's targeting large groups of people, which isn't always the case when you're getting to these smaller, more rural, hard to reach communities here in the States. So what we've learned overseas is most of the vaccines overseas are in these multiple dose vials. They have 10 or 20 doses because it's cheaper. It also requires less cold chain space. Here in the States, in our regular vaccine programs, they're single dose vials. So there's a significant difference. What we've seen overseas is that healthcare workers have come up with different strategies to reduce the wastage of vaccines. And we've seen some of that being replicated here, where you're setting up an appointment system, setting up the specific number of people, or you wait till the right number of people are coming there, so then you don't have to waste any of those vaccines. And that's just one of the things we've learned from overseas with this multiple dose vial packaging that we've already seen applying here, and how to make sure there's no wastage, because these vaccines are so special, because there is a high demand right now. To Dr. Talbot's point, it might change in the coming months, but to ensure that we are using all the vaccines that we do have available. We've seen the bat call at the middle of the night when there's 20 doses remaining and people need to come in right now to get them. So we've seen health workers adjust, and that supply chain adjust to this very specific packaging that the vaccine has.
Thank you. And Durrell, from your perspective, challenges you've seen and what can be transferable?
Yeah, I've talked about some of the challenges earlier, but working in HIV/AIDS for over 25 years, really focused on prevention and education and treatment, I see so many similarities. Increasing access to prevention education, how do we prevent ourselves from getting COVID-19, as well as some of the tools of prevention like PPE that are practically to apply. Those are critical ways that we addressed HIV/AIDS. Now I see us employing some of those strategies with COVID-19. I've seen more and more CHWs and other public health practitioners serving as trusted messengers, and I go back to this theme of culturally and linguistically appropriate information in a timely fashion to diverse communities to meet this challenge, to really truly try to help to close the gap and reduce the disparities in testing and vaccination rates that we've seen across the country in many communities of color and tribal nations, et cetera. I also think outreach, reaching people where they are in a non-judgmental fashion, that's one of the true tenets of outreach, community outreach. And I really see us trying to get to these settings everywhere where people live, play, and pray, including their homes. And that was really critical to our response to HIV/AIDS. And, there's been some challenges with COVID-19 because of the need to social distance and stay safe. So I've seen people be innovative. I love that, being nimble by figuring out ways to be physically distanced but socially connected. That's kind of a phrase that we started to coin to say we still have to be connected to our people. So if people have ways to connect virtually, I've seen folks use that. That's something we also learned with HIV/AIDS, but also doing some socially, some physically distanced face-to-face work. People have been doing porch outreach, driveways, parks, innovative ways to get to the people when a digital response design is not the most appropriate and the most effective. I'll also say that we learned a lot about partner notification and learning who had HIV and who might be affected by HIV or impacted by HIV. So now with some of the challenges of contact tracing, we really have to continue to tap into what we learned about partner notification. Also what we've learned about PPE distribution. You recall before HIV/AIDS, condom, dental dam, and other distribution, it was not a thing nationally. And we really did shift and change the science, behaviors, and accessibility to the appropriate kinds of PPE. And I see us having to do the same thing over and over again when it relates to COVID-19. So those are some of the things I've learned from HIV/AIDS that I truly hope others can carry, and we don't have to rebuild from scratch to address COVID-19. We have a lot of that, Ebola, HIV, and the other examples. Thank you.
Thank you. Durrell, I'm going to come right at you again with this next question. So, this is the MadPow Health Experience Design Conference. So thinking about human-centered design, what does that mean in, the response to COVID-19 and the vaccine distribution and administration? When you think about human-centered design, what does it mean for the populations and people you think mostly about in your work?
Thank you so much. I like this question. And for me, human-centered design just truly means having community members engaged in the design and development of the COVID-19 prevention, education, and vaccine distribution systems that are serving their communities. So they need to be consulted, they need to be partnered with, and when you're designing these systems. CHWs and other community-based and health care practitioners can work directly with other community members to ensure that anything that's set up in the community around COVID-19 testing and vaccination and the protocols that they use have a human connection. It means expanding access, working with community-based organizations, senior centers, faith-based orgs to see how they are connecting with their their residents, with the residents of the communities, and designing a system that really does appreciate and value their experience. I think that there are ways that we can embed CHWs and other community members to work with the folks who are the staffers administering tests and vaccinations, to truly kind of be that trusted partner, ally next to those vaccinators, next to those testers, who might be able to answer questions from community members, who might be able to help with some of the screening that goes on. So when I think of human-centered design, I think of designing something that brings me to a familiar place with a familiar face that truly does speak to me and my experience and pull me in. And that's kind of how I look at the human-centered design from a CHW community standpoint. Thank you.
Thank you, Durrell. Wendy, when you think about the people and the populations you're focusing on in your work, how does human design fit in?
And it's a great question. Some of our international experience, we've been part of the global vaccine demand hub. And through that, we did a service experience study to really understand from a human-centered perspective, the user perspective, what are the real drivers of immunization and programs around the world. And what we see is that many of those that we found in studies in Kenya and India and Mozambique, for example, are applicable here as well in this country. For example, how well an immunization session is organized really impacts the person's perception and if they are going to return for their second dose. The environment of the clinic, if it's organized, if it's dirty, if it's messy, if they have to wait a long time. How a patient is treated is a huge factor. If they're treated with respect, if they are treated fairly and just a nice health worker or not. If the vaccines are available, or if you have to jump through hoops. And I think one of the key things we're seeing here is the ease of getting an appointment. If you can, which we've all seen is a huge challenge, and it really it says a lot about our equitable or inequitable health system. There was a great presentation yesterday from, and I've forgotten her name, but in Massachusetts, where she herself developed an app to help people schedule appointments and find where appointments are available. That is a perfect example of this human-centered design approach, that one of the drivers of getting your vaccine is being able to easily get an appointment. And she's reacted and developed something that kind of helps that. So it responds to that human-centered driven need to easily get your appointments. The other perspectives we've seen is the public and private sector options. Overseas, internationally, the majority of health services and immunization services are delivered through the public health sector. Here it's a little bit different. We have more of a private sector, but in the smaller communities, the harder to reach, the more rural areas, the public sector is a huge conduit for delivering immunization services. And that is one of the areas that we need to it's a very important population. We need to build this unique approach to trust and ensuring that clients coming in are being respected by health workers. They can get an appointment. They know how to work the system, and really understanding their needs and being able to react to that. And the final part from this study overseas is this community health workers that Durrell has already spoken about, that is such an important aspect for reaching an equitable distribution of vaccines, making sure all communities have access to that. Thanks.
Thank you. And Dr. Talbot, I'm going to you next.
I saw it coming. Thank you, Amy. I'm listening with great interest to my other panelists, but I guess how I took this question regarding human-centered design, that was a phrase I wasn't as familiar with in my usual professional passions, which is tuberculosis. So I work for poverty-related disease diagnosis, and especially tuberculosis. And there we think about the cascade of care and how complicated that is in order to achieve our public health endgame of reduced morbidity and mortality, right? So, you know, to draw that contrast between COVID and TB a little bit more pointedly, in just 1 year, COVID-19 has been responsible for the loss of, you know, more than 3 million lives. And the world has really mobilized to bring the tools forward that are needed to treat. So we now have 3 different kinds of diagnostics: antigen, PCR, antibody. There are imperfections for sure, but we still don't even have that for TB, right? We now have a vaccine in record time. We have treatments. They're not any magic bullet, but this scale of response that we have all witnessed together is really historic. And I keep thinking, you know, how TB kills almost 4,000 people every day, and has really never received a fraction of the attention given, in part because we've missed the point of human-centered design or the actual cascade of care. So when I was working in Geneva with development of the Gene Expert, many of you know, is a 90-minute diagnostic for tuberculosis that really revolutionized, or could revolutionize, how clinicians approach diagnosis. I thought that was it. I thought it was the holy grail. And yet study after study continues to show us that if we do not take into account how people seek healthcare, how they see the clinic and the clinical staff, as Wendy has alluded, in order to do that equitable access of the service, in this case, the expert. And then if they don't get their results back, or the clinician doesn't know how to respond to the results, or the supply chain is broken and they can't get the medicines to treat their positive test, all of that together is something that we need to work on collaboratively. So in the context of COVID-19, surely we recognize this is more than developing a safe and effective vaccine, which we have now, but rather those delivery systems in place. You know, the speed with which these COVID-19 tools have come, tests, therapeutics, and vaccines, is really unprecedented. And I think that we likely should capitalize on this momentum to recover and accelerate progress against other diseases, such as my own disease of interest, which is tuberculosis. So the cascade of care is everything in what we do. There is no single holy grail that's going to turn this all around, but we need everyone in this response to take up their mantle of their role in addressing each piece of it.
So I have to say, Dr. Talbot, that is a perfect segue to my final question. You know, I'm trying to find the sliver of hope too in COVID-19, and I think we have mounted an incredible response, as you say. And the question is, you know, how do we leverage that? Where do we go from here? What did we learn from COVID-19 that can help us with the future of our healthcare and public health systems and our quest to advance equity? And it's for you, Dr. Talbot, if you don't mind.
Yeah, I could try. You know, you're right. I kind of took that on a little bit, but I do think that, so where do we go from here? You know, hearkening back to some of the themes that have already emerged from the 3 of us, I suppose, and more broadly, we need to learn from the lessons of the past. We need to see what's happening right now in terms of a complicated, dynamic space of evidence, guidance, and the like. I think we also need to recognize that we have to live with the balance that this vaccine campaign is presenting us with. It's great, right? I mean, imagine 6 months ago, we were hoping for a vaccine that had 50% efficacy or more. Now we're looking at vaccines that have 90, 95% or perfect protection against the morbidity and death of the disease. But while we're embracing that and rejoicing in that, if you will, I think we still need to wear our masks and socially distance and avoid the crowd. So we have to hold both of those things. We have to recognize we're in a time of a split screen. You know, thank goodness we got these vaccines rolling out globally. We need to do more for sure, but we also still have to keep with the basics. So that's a tough message for the public and even for me. You know, like, I want to move on. I'm right out there in front of everyone else wanting to move on from this. You know, we're all very tired. I think the other balance that declares itself very loudly at this conference is the balance of personal and public health. So I want to draw that out, and I'm going to say it bluntly, if that's all right. That, you know, hearing about the AstraZeneca experience. The AstraZeneca vaccine is likely to be the global vaccine, the one that's going to meet that last mile need, and to be what is given out in majority, given its cost, ease of production, lack of need for cold chain, all of that. And yet, reading about these rare occurrences of thrombocytopenia, disseminated intravascular coagulation, and central venous thrombosis, especially in young women globally, has been a heartbreak. I mean, that's not an objective read when I look at that and see that it may be related, and yet the global health authorities are weighing risk-benefit of this and saying AstraZeneca is still favorable toward continued and accelerated global rollout. This strikes me as a place of great disparity. You know, that I've always had the mantra of this trifecta: safe, effective, equitable, and I think it's not universally safe. You know, that there's always risk in any vaccine, and with this new emergence of potential side effect from that global vaccine, I worry that we are going to have a difficult time striking the balance of messaging and making sure that we honestly believe that this is in everybody's best interest personally and for the public health. So those are some additional comments, and I really look forward to hear what Wendy and Durrell, how they would answer this question.
Okay, how about you, Durrell?
Where do we go from here? I mean, one of the good things and positive things is I've seen the tide turning in the U.S. Around some of the ways that we're addressing vaccine hesitancy and access. So I really truly believe we are headed in the right direction. Ultimately, the paths that I think have been successful have solutions that always point back to the need to support and value community-based, community-driven solutions, you know, that reduce barriers and increase access to accurate, and I'm going to keep saying this over and over, and culturally and linguistically appropriate information and tools. Education that's developed and disseminated by trusted messengers, like CHWs and other healthcare and public health members who are part of or closely connected to the communities. I think this is the only true way and the only true direction to truly kind of overcome, or at the very least, get over the crisis of the COVID-19 pandemic. I also think one of the things that I really feel we have to embrace is trauma-informed care. Using that trauma-informed care, I think it's critical to helping us have a system where we're debunking, we're providing access to accurate and culturally linguistically appropriate information, but we're also debunking misinformation. I think Wendy or Dr. Talbot earlier mentioned that that's been a major crisis in addressing COVID-19, is the boom of misinformation, purposeful misinformation that helps feed some historical trauma, that helps feed some of the medical mistrust, et cetera. And so combating that by increasing knowledge and access to resources is one of the directions that we have to continue to go. I would say there's two initiatives in particular that really have embraced this need to build and focus on the community and support community solutions. One of them is the U.S. Office of Minority Health, who funded the National COVID-19 Resiliency Network. It's based down here at Morehouse School of Medicine. And it's also known as INCERN, that's the acronym. And they have community partners, trusted organizations across the country who they are supporting, who represent and serve communities of color, tribal nations. And the initiative is also supporting community health workers and other community practitioners with training and technical assistance to serve as COVID-19 ambassadors. They're able to increase access to information, not just for COVID-19 testing and vaccination and getting folks appointments, but also supporting and addressing the social determinants of health and the social determinants of health equity by helping community members get back on track with managing their chronic illnesses like asthma and diabetes and hypertension, as these are critical factors for folks who get COVID-19 and their outcomes. And there's also many community members who haven't been managing these illnesses. So I've seen people embrace the fact that we have to focus on COVID, but while we have connections with people, we need to also help them get in a better place with their overall health and the potential that they get infected by COVID-19. And we know their outcomes will be worse if they're not managing the illness. The other group I'll mention very quickly, because I know we're short on time, is the U.S. National Institutes of Health funded something called CHW, the Community Engagement Resource Alliance Against COVID-19. And they too have been working with community members in community spaces with open forums, trusted messengers, and they truly have taken on the vaccine hesitancy piece. And mind you, some of the disparities might be about hesitancy. A lot of the disparities are about inequities in distribution and allocation. So pandemics, natural disasters, and other crises will come and go. We truly need to build and sustain, this is where we really need to go, a public health infrastructure designed with a health equity lens that adequately addresses the social determinants of health and the social determinants of health equity. A community-centered design with communities and community practitioners as partners, guiding the design and development of quality, adequately funded public health infrastructure. This is truly a response that we need now. We don't just need it now in response to COVID-19, we need it now and we need to sustain it. Because once again, we will be on this road again. I'll stop there because of time. Thank you.
Thank you very much, Durrell. So Wendy, looking to the future, implications for our lessons learned from COVID.
I want to pick up on a couple of things. First, Dr. Talbot said if she had a few couple words early in, resilience, nimble, and flexibility. For the supply chain, that's what we need. That's what we're going towards, right? That to have a supply chain that can react. How many of us ordered something on Amazon Prime yesterday and it's now sitting on our front porch, right? That's the type of supply chain that we could learn from the private sector. And now with all this attention, there's been a ton of attention on the vaccine and supply chain, which I love supply chain. I'm a supply chain geek, so it's great to see this much attention. But how do we leverage that now into strengthening the overall supply chain, which is what, and overall public health and the health system that we have here. And Durrell just mentioned sustainability, and that we have this great opportunity right now because we are seeing a lot of human-centered design perspectives come out. We're seeing a lot of reaction to this global pandemic. How do we leverage that energy, that attention, that focus to continue to strengthen our overall health system? Because that's what we need to do. Especially the last mile, and I think this is in the chat, like how are we reaching the last mile communities, those homebound communities? That's going to always be the most expensive part of delivering a vaccine. How do you balance that out? Because it's just as important as the person next door to a clinic. And how do we have that equitable lens to our health system, leveraging all this energy and attention right now, so then we move to a more resilient and flexible supply chain to then support a stronger health system overall.
Thank you all very, very much. You're all so inspiring. Margaret, I know that you've been monitoring the chat.
Yeah, I have some wonderful comments that people appreciate many of the things that you've said. I'm going to lead, though, with a couple of questions, and I would invite everybody to look at the chat because there are some really good ideas in there as well. One of the questions was about hesitancy being met with shame in communities and social stigma. And health communications typically try to focus on the positivity aspects. But the question is, first, does that work? And what are other strategies that we might take to address hesitancy in addition to the rah-rah, this works, or does the rah-rah, this works strategy work? And Durrell, let's start with you on that.
Yeah, I mean, HIV stigma is still alive and well 4 decades later, so it's something that we have to continually address. I truly think that having people help design the messages, I talked about linguistically and culturally appropriate, and I really think that's part of it. I mean, part of it is having, offering something in a language and it's something I can understand and know. Having something I'm familiar with, and I think that's part of it. I also think facts, really combating myths and misinformation and hesitancy with solid facts from trusted messengers also has been a critical role, and that's what the role that SEAL has been playing, where you have clinical providers, scientists, community practitioners, all working together on a team who can really articulate in a way that really resonates with many communities where some of these other messages have not. And I think that's the way we do it, and really addressing the fact that there should be no shame and stigma related to this or any other disease or illness that is killing people. We have to, but in a respectful manner, we have to address that stigma. Thank you.
Mm-hmm. Great, thank you. And then there's another question. I think we hear about this a lot, those of us who work in COVID, and that is the frustration people have of using online platforms. So they open and there's a pent-up demand and everybody goes on at the same time to try and make their vaccine appointment. And the participant chatted in that you have to refresh the screen constantly. And that's if you have the patience to refresh the screen constantly and sit at your computer waiting for that to happen. What other strategies are available? And I'm going to put that out to everybody. And some of our participants have chatted in some things that I'd like to highlight a little bit. But I'll put that question to any of the panelists who wants to address that. How do we deal with this online jam? And are there other tools besides the online jam?
I'll start. I think Dr. Talbot too. One of the things I've seen is walk-in hours that have outreach workers, community health workers attached to them who go out in the community and bring people in. No need for paper, no need for digital. They connect with you and they do a warm handoff at the site to one of the slots that's open for walk-in. I've seen that work in some communities.
Mm-hmm.
I think we have to recognize in public health, we have to have the resources that one size doesn't fit all. Like the ideal would be we just put it on in the web, we put these websites up and good luck to you all. Like Hunger Games, right? Vaccine games. But we see that the best vaccine distribution has to be through multiple ways, right? So going on a website, that works for some. Making sure that you have the bandwidth to do that and not encounter all this frustration, that is working for everyone. But we also have some of those things like Durrell said, you could just show up to an equity clinic. You don't have to pre-register, or you can make a phone call. Maybe that's the technology that works best for you. Maybe you want your doctor to register you or your trusted healthcare provider. So personally, I wish we had one size that fits all, but we recognize it doesn't. And you're absolutely right. I've heard from many other states that their selected system didn't work well, and not to cast blame about, but some of that also was driven at the federal level by the VAMS system, which already wasn't equipped to handle the kind of volume that we were going to see with vaccine. We were required to use the CDC system, and there were some significant shortcomings that trickled down to our end users, which is, I think sad to see. So nimble, flexible, multifaceted, patient-friendly, taking all those things into account, going to be really critical.
And one additional thought from our international experience, and I've seen this in the chat as well, is that community outreach, and Durrell also spoke about this with community health workers, through community leaders, the religious leaders, outreach workers, community health workers that know their community, that have mapped out in like small communities. We're not talking about the suburbs. We're talking about this neighborhood is mine, for example, and I know every person, I know every baby. And following up, knowing who's gotten their vaccine and who hasn't gotten their vaccine. And again, it's like such a diverse way and dispersed way to do it, but it's that level of detail and attention to find those who are vaccine hesitant, and use a lot of the design conversations that we've had this, and the theories and the thoughts behind it that we've had these couple days, of how to really tailor messages specifically to people and to make them willing to listen to them, essentially.
Mm-hmm. Thanks very much. And I'll draw your attention to some of the comments that are in the chat. Jennifer has highlighted what's happening in DC, and at JSI, we've actually been following what's going on in DC to offer multiple platforms for people, including the old-fashioned telephone and outreach to unhoused people to help them get vaccine. Nadred has left a number of connections and websites to tell us about social workers and a Massachusetts effort that works to help people connect with vaccine. So there are a number of those in the chat as well, and a couple are highlighting various places. David Resnick puts in that their home care is also doing at-home vaccines, and many states have contracted with VNAs and other community-based organizations to take vaccines one by one to individuals. And as Wendy mentioned, there's some challenge in that because of the way vaccine is packaged in the United States and how many doses you must get and must use within a fixed amount of time. So thank you for sharing those pieces of information. And vaccine, there was also some question about vaccine confidence among the people who are healthcare providers. Did they have confidence in the vaccine, and did they share that confidence with the people that they're providing care to? So thank you very much for all of that information. And I guess I'll close it then, because I don't know if the chat stays up, but there are some great websites and ideas for people because you're all living this experience as well as we are. So your information is valuable as well. So I just turn it back to you, Amy, to close out the session for us, I think, if you'd like.
I did see Dr. Talbot raise her hand, so wondering if
I'm sorry. Yes, thank you.
Not to slow us down from our lunch or what, but I keep thinking back to the questioner around shaming and vaccine hesitancy. I do believe, as said before, that we're going to all have to pivot to be trusted members of our own communities in order to get our vaccine uptake rates high enough to break the back of this pandemic. So language is so important, starting with the fact that the Operation Warp Speed chose that name, which I think, already cast some concerns for me around a warped program. But indeed, let's be careful with our language and never shame people, whether it's TB, Ebola, HIV, whatever. That is not what we do within any of our jurisdictions in public health and the best practices. So I was very impressed with the debunk survey. So I wanted to also offer that as a resource. It's focus groups, it's questionnaires and all for vaccine hesitant people. What is the most effective language to bring them toward a closer space of vaccination? Surely each one of us needs to have our own concerns addressed, but then after that, it's largely around discussing benefits of taking it as opposed to consequences of not. And I love the evidence base now that shows us it's not effective to talk about people being being misled or confused about the vaccine, but rather accepting that people may be skeptical and concerned. So just that one final comment, because I want us all to be really ready to do that pivot from the intense vaccine demand we're seeing to beating those bushes and getting us up to herd immunity and putting this behind us. So thank you for that opportunity to offer an additional passionate plea.
And I do see a couple of items in the chat now, just talking about how personal stories can be so powerful. And, again, taking that positive light, on the benefits that we can all have together. So we still have 5 minutes, I believe. So I'm wondering if there are any other questions from the audience. If not, I hope you all go forth and do your part to talk positively about vaccine and the importance of everyone getting vaccinated and help public health address everyone's concerns around the vaccine in the best possible way. And thank you very much.
Thank you, everybody.
Thank you. And I want to thank our panelists and all of you who took time to participate in this, and go out and share your stories. Thanks.